So I agree with you, Francis, that digitization is the way to go. And why am I saying this? One of the biggest problems that we have had in the facilities with regard to reviewing cases is lack of the tools, either the notification forms or the review forms. So sometimes they are there, sometimes they are not there, sometimes they do photocopy, and sometimes we don't even have a photocopier in the facility. So as you are saying, if we had these at the touch of the button, with the having a system whereby all these documents are available, where people can download, use them, or even use them directly on the system. I think like KHIS, I'm not very sure whether you have we have such a tool where we can just put the information directly. I think that would be useful. All I know is that digitization has been one of the strategies that the Division of Reproductive Maternal Newborn Health is undertaking. And I mentioned the digitization of the tool, the standards MNH standards assessment tool. I think that is one of the tools that is being undertaken for digitization. But I agree that all these other tools needs to be available at the health facility. Maybe Scholar will be able to explain how far they are doing on that. Yes, again, the issue of the point of care ultrasound, and it's good that Veronica has clarified that actually these equipment are being supplied in facilities, which is good, because one of the problems that was identified in the CMD is challenges with delayed diagnosis, and then after diagnosis taking too long to make treatment. And again, one of the recommendations was having these diagnostic tools and services being available in maternity. So the challenges are there, as you have mentioned, in terms of accessing the service when a cost is put. And why is this cost being put? Because of the cost of the films. I don't know whether they are called films, to produce the image, and whether a policy can be made on this. I think Scholar is going to be the one perhaps to respond on this, because as long as we have a fee, then of course access is a problem. But I believe these are some of decisions that can also be made at the county level and at the facility level, because if we continue waiting for the national level to make some of these policies, then it takes too long and our mothers will still be missing the serving. The skill gap is still there, and I believe it's not, we have reached a point whereby it's not just the department, what do you call it, the radiography department that has to do this ultrasound. The midwives should actually now be trained, the clinical medicine, to be able to do these tests, because it is point of care testing. It should not be that the mother is being sent somewhere. So I don't know whether a Scholar would want maybe to add something. I may not be very good at what the ministry is doing.
Okay, thank you, Onesmus. I may not have a very conclusive answer for that, but for digitization, that is where we are headed. Through the Department of Informatics in the ministry, we are moving to digitize all our information. So I don't know how long it's going to take, but it is something that is ongoing. It's in progress. And we hope that in the future, we'll have all our information digitized, and we'll be picking the information from there. About the review forms are already in the system. So I think it's just a matter of having the connection, the internet connection. You can still do it directly into the system. Though we decide to use the review forms and then allow the sub-county or the HRIO to go and upload later, but it is provided for in the system that you can upload that information as you discuss. Is it, Kerich? Yeah, it's there. And then the other question on what? On ultrasound. We are doing all that we can possibly do as a division. Remember, there are how many, if you want to involve the midwives and the radiographers, these people have to agree on task sharing or task shifting, and that is where now the problem may be. But it is not like we will stop trying. We will continue trying until a time where we will comfortably have a midwife doing those ultrasounds by the bedside. Yeah, okay, 2 more questions for Nelly, and then we'll see if we'll do another one question round at the end. So please just hold your question. Just hold. Now I'm taking questions for Nelly. Anyone for Nelly? You remember Nelly? Oh, but opportunity to relax.
Thank you. Thank you. Thank you so much, Madam Moderator. I was just thinking as you were presenting, in Kenya right now we are looking at increased facility delivery. Skilled delivery is at 89%. Health facility delivery is at 82%. In terms of ANC attendance, again, it's not about attendance. The demand is there. Very high uptake of ANC. What could be the problem? Because a lot of those components, if we have such high access to healthcare services, then why is it, what is happening? Is it the second D or the third D? Where are we failing in terms of identifying danger signs, in terms of responding, intervening on time? And I really feel also another component that is also cross-cutting based on the CMD interventions is one thing that I was keen to hear is the introduction or product introduction, especially some of the essential commodities like carbetocin, you know, where we are talking about PPH being the lead killer of these women. Where are we moving so slowly in such interventions? Another component is health financing. Health financing is something we are not talking about, but it embodies everything that we do. For example, resources will always be limited. Access to these diagnostics will always be limited. But if we can maximize on health financing mechanisms, how are we able to think about sustainability in the long term and also strengthen quality of care? Thank you.
Your question was for who? For all of them. So decide who is going to put it. Okay, question for Nelly. Okay.
First of all, just to say thank you so much, Nelly, for the research. As part of the methodology, you indicated that you looked at the 126 out of the 252 deaths that are related to the CSS that had been done in 2014. I was just doing some brain gymnastics, wondering why 2014, why not 2018? Because we are looking at 0 deaths. That is where we are moving to. How is the trend currently? Are we likely to get there? Because a figure of 5%, that is quite alarming. Thank you.
Okay, one more question for Nelly. You got it. You got the question. One more question for Nelly.
Thank you, Moderator, and thank you, Dr. Nelly, for the presentation on the risk factors. On the recommendations, you mentioned that the mothers need to be referred early and adequately, they should be adequately resuscitated. It isn't clear what adequate is in terms of resuscitation. And then experienced health providers to do the CS. Again, it is not clear who experienced are or is. Thank you.
Okay, thank you, Janet, for your question. Now to you, Nelly.
Thank you for thank you for the question. So I'll answer some and then I'll hand over to Professor Charles Sami also to give his input. So the first one is on ANC visits, and you correctly put it that ANC visit attendance is very high. Even when you look at KHIS, it's really high. But the challenge is not whether they are coming for the NC visits or not. We actually came to realize that it's the quality of services that they get. So they will come for NC visit, but when you ask them what actually happened during the NC visit, they may not even, you know, tell you what they learned or what they were told or what was done. And there are so many challenges to the same. I currently work, I can say, in primary healthcare at the sub-county level, and most of the challenges we have are commodities. A mother will come and we're not even able to do an ANC profile. So yes, she has come for the visit, but what care have we given? What quality of care have we given that mother? So that's one of the issues that I can answer concerning that. And the second, the Professor Charles will give his input towards the second part of your question. So I'll go directly to the question of the 126 vis-a-vis 252. So it was not the 126 out of 252. 126 were the cases. Those are the maternal deaths. According to the report, the number of deaths were 138, but when we looked at those case notes, some had incomplete data, some did not have adequate data, and we could not use those case notes. So the ones that we actually had to use and were able to go through were 126. So we had to match those cases with controls with a ratio of 1 to 2. We had 252 controls. And so these are deaths that happened in 2014. So the inquiry was done in 2014. That's the data that was used. So it was only prudent to use the same year's data to look for the controls as well. But the report was actually published in 2017. For the recommendations concerning early referral, so early referral, referral is in different stages and different phases. By the time a mother actually gets to a facility, most of the times maybe a level 4 or a level 5 facility, the referral started way down from the community level. So when we are talking of early, it could be from any of those levels. And by the time, sometimes a mother comes to the facility, yes, it's a level 5, but it's how do I put it? It's late. There's nothing much they can do. Yes, they have come to the facility, but they have come at a point where there's no intervention that can be done because the person has come in late. And the delay, we have the 3 delays, right? So there's the first and the second and the third delay. So the delay could have started way at the community level. It could have been referring from the level 3 to the level 4 that took time. And there are so many factors that interplay at that level as well. So the recommendation when you talk about early is at the level where you're at that you get the mother as a healthcare provider, then refer in good time. If you do the blood pressure and you find it's already high, don't start, thinking maybe I can buy it another 1 hour or 2 hours. Like we had an incident where a mother had labored in a facility for 24 hours. Surely 24 hours is too long. A decision would have been made maybe by the 3rd hour or the 4th hour, instead of allowing a mother to labor for 24 hours, yet they have a contracted pelvis or something like that. The other one was experienced versus inexperienced healthcare workers, what that meant. So from the study, when we asked who did the CS, so we have interns, we have MOs who are maybe 1 year experience or 2 years. Then we have the senior MOs, someone who has worked in that OBGY department maybe for 4 years, 5 years. Then now we have the registrars for facilities that are privileged to have some, and then now the consultants. So there was that variation per se, that if it is just a facility that only has maybe interns, or most of the CSs are done by interns, then you find that the odds ratio was slightly higher compared to the consultants. Yeah. So Prof can.
Yes, thank you. So I think she's responded to the experience and then adequate resuscitation. So you have those patients that arrive in the healthcare facility and you are finding it difficult to even record blood pressure. There's some pulse, blood pressure, you're struggling. I mean, even if you were at an intensive care unit with all the blood transfusion and 10 consultants, you will struggle, with a lot of prayers to come round. So if they're adequately resuscitated before coming, maybe they stand a chance. And then you talked about heat-stable carbetocin. So why don't we have that discussion after my presentation? Because it will, yeah. So, okay.
There's a study that was being done, a pilot that was happening in Pumwani. I think it was some facilities that we just got disseminated results. I mean, the results were disseminated the other day. So it was actually a trial or a pilot study to see if that carbetocin can actually work. And it's something that is in the pipeline to be scaled up to the other facilities.
Okay, thank you. Our panelists, I know there are those who still have questions for them. They're still here with us. I hope, Nelly, you're not going back. You'll not be around. Oh, but Professor will handle the questions. So we'll allow them to go back to their seats and take up our next presentation, session 4. So thank you for answering those questions. They were tough questions.